There we are. Hey, everybody. So good to see you guys. That live button almost confused me there, Thea. Looking this week, we've got some big news that Thea and I have wanted to talk about for what, a month now, Thea, basically, at least a
Yeah,
couple weeks. And so we wanted to reveal it to you guys with the 2024 proposals coming out. These aren't definitive. Don't take anything as legal advice. Make sure you're associating all of our commentary as just commentary, kind of looking at what's being proposed. And actually, a lot of these things being proposed have not been finalized, right? And they're just in the works. Some other things that Thea and I will talk about were ones that have already been taken care of in the 2023 proposals and then became finalized. But these ones will be really good insights for you to prepare for what we can do potentially in the pharmacy world and remote care services world coming very shortly. I'm going to hit our reel, Thea, and then we're going to jump right into it. Thea, I've missed you. It seems like it's
I
been way
know.
too long. I've been traveling. You've been traveling. We've been busy on lots of different ventures, but 2024 is happening like, what, 4 months away? Like, give me a break. That's
That's
ridiculous.
8 paychecks until Christmas.
Oh, not the 8 paychecks calendar. Oh no. Oh no. So speaking of Christmas coming along the way, I think there has been some news that could be Christmas for, we thought maybe for some rural health clinics and FQHCs. I know that was one of the big announcements, but I'll let you kind of roll us in.
Yeah, for sure. Remote care services are getting enhanced, and that is so exciting to me. I think that remote patient monitoring and remote therapeutic monitoring are getting the biggest bump right now, as they have really seen the value even post-pandemic-ish, where we stand today, and how these models around these particular types of care management, adding that data back in, is really showing up and showing its value. And federally qualified health systems, as well as rural health systems, are going to be able to bill for these now. That has always been, in prior years, that this has been under the primary care coordination code of G0511 in the past years. And we really haven't seen much in the way of CMS coming out and saying, we're supporting these programs. And even though we're helping these clinics, which is the entities that are designated the rural health clinics or the FQHCs, because they get a different money allowance from the federal government, they have always said care management is so important, but we don't want to pay extra for it. But now they're seeing the value in what CMS and what remote patient monitoring and remote therapeutic monitoring are really able to do. And that is moving forward. Now, with that being said, it's not super clear as to what the reimbursement model is going to be. They're still waiting for commentary to have providers feedback to CMS to see maybe more thoughts on that. But it does look promising that remote patient monitoring is going to be outside of the care management code of G0511 and into its own code. So that is going to be super helpful because the reimbursement just wasn't there to be able to add devices to these patients and really add that value. So I'm hoping that that will come out in the wash, that we get to bill for the codes, not only for the device, the data that is collected, but also our clinical time. And hopefully there's 2 codes there or more, but 2 would be a great starting point, in my humble opinion, to get us moving with the FQHCs and rural health clinics. So that's one of my favorites. The other one is around 2 new care management programs that they're rolling out. One is the, Principal Illness Navigator, and then the Community Health Integration programs. These programs are really driven for patient outcomes. Really sharing what the value of healthcare is today. I know, Kevin, you had that quintuple aim pulled up, ready to go over, and it really is where value-based healthcare is driving to. The quintuple aim is basically the clinical outcomes, the patient experience, provider satisfaction, and hopefully not burnout, as well as the financial stability and sustainability of our healthcare system today, really trying to preserve as much money as we can for decreased readmissions and hospitalizations that are unneeded necessarily if we are doing our share of preventative care. Really taking a look at, we want Medicare to be around for years and years to come, as we are all paying into it right now. So we need to make sure that we continue that model. And then health equities, a lot of emphasis around social determinants of health and what the health equity across the country really is today. And I feel like these are really the 5 aspects or pillars in my mind of where healthcare is going in this value-based world.
Yeah, I love how you touch on it at the end, kind of going through the grouping. Like we did not have a quintuple aim just a little while ago. It used to be the quadruple aim, and we
Yeah.
added in providers, to that experience. We had such a massive burnout period in realizing that we're losing folks in the medical field, that has to be part of the aim in general. And now we're seeing a pretty big emphasis on the health equity side of things. You mentioned a couple new programs that are looking at social determinants of health and how they're working to make sure that those individuals that are disadvantaged, they get the services that they need, and we can provide a few new individuals to play roles in that. And you mentioned one of them, Thea, with the principal navigator kind of component. And if they are having a significant and or serious illness, we have the ability to use other care providers, kind of ancillary individuals in those roles. One thing to mention too, as we talked about, and I'll pull this screen down for us. One thing we talked about is RPM, looking at remote patient monitoring. And that remote patient monitoring, one thing that did not change is the 16 days is still going to be required. CMS is not backing off on that. They're making sure that the monitoring requirements in that 30-day window are 16 of those days have to be monitored. They didn't say data transmission in the most recent update, which is fascinating and leaves a little vagueness. But I'm guessing it's still along those exact same lines we're accustomed to. Another one really is in 2023, one overlooked piece, even from some folks that I was consulting with back then, is that they didn't recognize or see that RTM, even though it was general medical and not E&M like RPM, was changed to an incident to general supervision code. And so we have the ability, once again, to partner with individuals that are primary care providers and able to have an incident to designation to leverage folks like pharmacists and nurses to do these tasks and take care of them and push them through as a billable service under incident to billing. And so there's some big pieces there. But the other thing, Thea, I think is really interesting in the RTM, RPM piece is how CMS really highlighted one big thing. They're complementary. So they're really looking for those RPM, RTM services never to be built together. Interestingly, we can talk about that in a second, but for them to be added on to chronic care management, behavioral health, and principal care management, transitional care management, some of the other management individual codes. So now we can bill for 2 things. One, the overall management and review, that dedicated element that you and I have talked about so many times, that you can't just take a snapshot and hope you're going to change a patient's, trajectory. You have to have a long period of understanding their regimens and the next steps they need to take. And also a big piece of that is that daily monitoring and access to data coming back to us through those RTM and RPM codes that can be built in or billed for in addition. But anyway, Thea, any thoughts there on that CMS emphasis? I know it's something that you've always talked about, that dual billing capability of the two.
I think they just really go hand in hand. I think they add so much more value to the practitioners who are getting the care plans that now have the data and the reason why my recommendations are what they are. If we're in communications about changing a regimen for whatever reason, I think it just adds value to how the patient is doing at home. And I think that's the most valuable thing that any provider could ask for when they only get 7 minutes with each patient. In the real realm of things, 7 minutes isn't enough. It isn't enough to care for acute care, let alone their chronic medication needs and chronic disease state management. I just think having these programs complement each other is an amazing asset. And I've been doing these codes for remote patient monitoring and chronic care management for the better part of 4 years. So, I mean, I have seen the value of what these 2 things put together really can deliver upon. And, there's caveats to it, right? You can't double dip with your timing. You have to spend 20 minutes of time on one program and then 20 minutes analyzing and spending time with the patient in the other program. So, I mean, there's ways to get it done, but when it's it's done correctly, I think it's really, really beneficial for the outcomes for the patients. And, when we looked at that quintuple aim, patient satisfaction is a huge pillar that patients get to fill out surveys on. They get to have a voice in this healthcare, and that changes the star ratings for physicians, for health systems, to really have to dot the I and cross the T of all patient encounters. And I don't know a better way to have enhanced patient encounters than having a clinical pharmacist call each patient each month to ask how they're doing. I just think it's an amazing opportunity for pharmacists out there.
I'm glad you segued into my bone to pick with everything here. So I think one thing that's great is we recognize that FQHCs and RHCs, me being a rural health, native health guy, that drove me nuts. Like, we're inventing programs that can help people in rural areas to be able to monitor them and add services. And yet we totally miss out on the majority of all available clinical resources in the areas with FQHCs and RHCs, and leave them under the bus when it comes to RTM and RPM elements. So seeing that rectified, the big win. I hope CMS sticks to what they're trying to do there and they get that done. And then a lot of these FQHCs and RHCs take advantage of that and can bill for these individual services to help those patients in remote areas. I think the other piece that is the big bone here for you and I being pharmacists, RTM, like we just mentioned, that it is general medical, which is wonderful. Pharmacists can now get involved in something that is called remote therapeutic monitoring. Like, I don't know anything that can be written anymore that says this should be done by a pharmacist. But when we see the individuals getting recognized as individual providers under this general medical code, I'm saying physical therapists, occupational therapists, I think speech therapists, audiologists, I think are all in that list, that they can directly bill for these things and not have to go under incident 2. Everybody that's out there that is a major pharmacy leader, what's going on? Like, why are pharmacists not included here? I'm talking to you, APHA. I'm talking to you, NCPA. I'm talking to all of the big guys out there that are watching out for us. Get on the horn and make sure that we're added to these things on CMS's websites. I totally understand that the ECAPS things and everything else are high on the priority list for immunizations, but you know what pharmacists are really, really good at? Remote therapeutic monitoring, and we should be listed on that list. So I'm going to step down off my soapbox and then breathe.
Well, here's an interesting fact that I didn't know. Back in 2014, a group of family practitioners, family medicine, pediatric doctors went to CMS and got it approved that pharmacists are qualified health providers. Even though we can't bill, we are listed as of 2014 as a qualified health provider. So a lot of regulations state that that's not the case. But I was talking to Jaron Stout about this just a couple weekends ago when we were at American Society of Consultant Pharmacists outing here in the Mid-Atlantic states. He was telling me that that document does exist. In 2014, and it wasn't even pharmacists that brought us to the table. It was actually family practitioners who had a pharmacist in their office doing some amazing stuff, and they were able to get it added to CMS's list, which surprises me that we haven't seen that before, because I've been in this field 7 years about, either diving into it or actually doing it for the past 5, and I've never been able to see that document. So I just wonder if there's more information out there that we can find, that we can have these big organizations who speak for us all as pharmacists really take it and show, hey, we've been in this list for a while now, but you're not including us in the verbiage. How about you start including us in the verbiage?
Yeah, and I think the beautiful thing for you and I too, Thea, is we know a lot of states have already pushed that beyond that envelope, right? We're already qualified healthcare practitioners or providers in individual states, and required by those states, those Medicaid programs and those commercial insurance programs providing care for their state, individuals. You have to make sure a pharmacist is getting reimbursed at the exact same rate.
Yeah.
And so I think there's, once again, another push. And, when it comes to some of these opportunities, when it comes to qualified healthcare provider, like the physical therapist, occupational therapist, audiologist, like there's not an overarching ability for them to do all services, right? And I'm not even asking for that. I'm saying that when there are services that make a ton of sense for the specialty of pharmacy, the medication experts to play a role and directly bill for services for patients, like remote therapeutic monitoring, we need to be on it and highlight it and said, hey, this is where exactly patients should go to be able to receive these types of services. And so I think there's that element that it really comes to. Great, we took care of our remote services folks. They were taking care of remote areas now by allowing FQHCs and RHCs to jump on the board. But we also need to make sure we're taking care of the profession of pharmacy by allowing them to avoid the incident to billing element and step for the things that make a lot of sense for them not to go through that component. There still needs to be a relationship, just like there's going to be a relationship between the physical therapist and the primary care practitioner to make sure the patient's doing well. That's very obvious and practiced, already in medicine. And so that doesn't take away from it, but it does take away from the ability of patients in these areas where they're able to see a pharmacist whenever they want to be able to get access to care. So there's the drum.
There it is. Beat on that drum. And you're in Washington and have rural health clinics out there. And I'm in Pennsylvania and I have rural health clinics here. I'm in Northwestern Pennsylvania. It's like, I call it the armpit. There's nothing here. And there's not a lot of health opportunities here either. So we do have rural health clinics and critical access hospitals in our area as well. And we need to show up for those patients a little bit better. And I think CMS is trying to get there with these new opportunities and really what it's going to. So I think it's a great thing. And I say, if you have the opportunity to speak to some representatives in your local area about what pharmacy is doing, I think there's a lot of organizations out there that have pieces that they need endorsed. So look up your favorite organization in pharmacy and get active, because we need to start showing up for our profession. So there's my soapbox.
Oh, that's perfect. Yeah. And I know that a lot of the law firms out there and a lot of the service providers, that are out there that have either a vendor relationship, whatever the case is, with these individual specialties, even advocate for, make sure your voice is being heard and contact CMS relating to how you feel like these next steps should be taken. Because right now is the time where a review for this next proposal and finalization has to happen. In fact, a lot of times when you have these proposals that come out, one thing that Thea and I will have to go over sometime is there is CMS asking for stakeholder opinion, for us to be able to send it back. Do they always listen to stakeholder opinion? No. Sometimes they've got a lot of data and metrics and money that need to be moved around related to, we can't let everybody go through only 2 days of observation and not the 16, because that's going to open up a can of worms for us. Like I totally understand there. But when it comes to some of the other stakeholder opinions on how are some of these technologies being deployed, what are some of the abilities and inabilities of us to be able to bill for these services, or the limitations with the ways the rules are being written, this is a great opportunity for your voice to be heard. And to do so, we'll add some show note like links related to how do you get your voice out there and how do you connect with those CMS kind of components. But otherwise, the only last thing I wanted to plug on, Thea, was this. The SDOH elements that are really being highlighted through a couple of these new initiatives inside of CMS is really interesting, because a lot of the SDOH pieces fall back on and connect to value-based care elements. And so the value-based care elements that are being pushed out there and being changed, are happening. We saw some changes in the proposal for ACOs and how their risk adjustment scoring is happening. And we're seeing some changes to what you and I mentioned right before we started with universal foundations, and seeing that there are new metrics to get aware of. And so in a future episode, Thea and I can both talk about, like, here are some of the metrics that CMS is really starting to emphasize. So you as a healthcare practitioner can start to recognize, as I get to be folded into these opportunities of value-based care and see how the needle can be moved, what things are they caring about? They being primary care practitioners, ACOs, and payer organizations. What do they care about that are really changing for their individual patients, and how are they being reimbursed for those changes, and see how we can play a role in making those things happen.
Yeah, that is 100% a whole video on quality metrics and how it goes, and adding in social determinants of health. That's still unfolding. So we'll be finding out more as these proposals come to play. But I think it's an opportunity for us to show up for our whole country, which is amazing.
Beautiful, beautiful. Love it like always. Only big ones for me are join RPH Ally. Head over to rphally.com, join Thea's channel, jump over to Remote Care Services and jump in there and talk about the things that you're doing, ask Thea questions, take some awesome courses that Thea's putting together if you need to get some information on that, and then jump in and check out our Sweet Soiree. We still have tickets and recordings on that. And so you can see Thea did a fantastic presentation on all things care services, remote care services, and a peek at that, along with another 20 some individuals that talk about their specialties in pharmacy and their expertise. Thea, what other things did I forget?
Nothing. I think you wrapped it up nicely. I'm excited for everyone to see the video and know that we'll be back next week.
Love it. Talk to you guys soon.
Take care.